factors are too, oh, there you go. I'll come back and do it on the back end. That risk factors are just too common to be useful. We've all looked at these forms, that risk factors, they're just very common things, particularly for many of us working in certain mental health contexts, that these variables are just, if not ubiquitous, close to it among our clientele. Also, there's variability in terms of how important a given risk factor is for a given person. So that for some, in some cases, depression might matter a lot in terms of their quote unquote risk, but then in others, it doesn't matter at all. Another, and I alluded to this earlier, is that we're generally interested in the probability of attempting or dying within the next 24 hours, right? So let's think about risk factors in the context where I would say, and I'm not an expert on this stuff, I would say they're relatively useful. When I go to my physician every 5 years or whatever, she does sort of the full workup, and she has this sort of cool mortality risk calculator thing that shows up on her computer. And then she's used, so she uses all my demographic variables, my health behavior history, other stuff, my cholesterol, body fat percentage, smoking behavior, um, family history, all these sorts of things to sort of say, all right, let's look at his mortality curve or mortality risk, and then use that to inform sort of this proactive, hopefully, intervention, right? Like, hey, it looks like this is a little bit high, or because the most of the men in your family pass away from cardiovascular, da 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 da, you should consider doing da 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 da, right? So that seems relatively stable, or that seems relatively reasonable, but there are some reasons why that so there's some major differentiations between that and what we do with suicide risk assessment. So in suicide risk assessment, the predictors are extremely variable or much less stable. A lot of these variables like suicide ideation, how down are you feeling, how much is life worth living, those things can vary and fluctuate dramatically, within a couple of days. Where when we think about the predictors in that sort of health context, they're much more stable. It's not that they're not variable, but they're more stable. Your cholesterol, your body fat percentage, your smoking behavior, those things change slowly versus ideation, intent, relationship strength, emotional states. And then also, and I think this is so important, it is that time period. So that when I meet with my physician, she's talking about the rest of my life is what she's talking about, which is, 30, 40, 50 years, whatever it happens to be, and looking at prediction over that really long term, which is very different than trying to predict something over the next 24 to 72 hours. And in fact, when you look at most of the suicide research on risk factors, protective factors for suicide, most of it's, over the next year, over the next 5 years. Like that's usually what this work is doing. And as a clinician, when we're doing risk assessment, typically we're really interested in the next day, 2, 3. Did I miss one? No, I think we're good. Okay, so I've given you a bunch of data and make some arguments that are hopefully pretty compelling. And usually when I give talks, I don't like to give quotes and like read off of slides, but I'm going to because I think that this helps to drive this particular message home. And how I take this, so these are all from researchers that I think a lot of researchers, in fact, I've talked to several who really get into studying risk factors, thinking that, oh, yeah, sort of like how I was like, oh, yeah, this is useful, this is important stuff. But then as they do the work, they come to realize, wait a second, this isn't really what I thought it was. And oftentimes they communicate that, usually in discussion sections of their articles. So let's see, what time is it? Okay, I'm still looking at time. So this study, so Franklin and these were a bunch of folks up at Harvard out of Matt Knox lab. They did like basically the largest series of meta-analyses looking at suicide and suicide-related outcomes in the history of ever. And so they wrote a ton of papers, published in Psych Bulletin and these sorts of places. But anyway, so in this one paper, I just think that this is a worthwhile quote to read. So these broad analyses showed that overall prediction of suicidal thoughts and behaviors is poor in terms of odds ratios, hazard ratios, and diagnostic accuracy statistics. Specifically, odds and hazard ratio analyses indicate that existing factors do not substantially increase the risk of suicidal thoughts and behaviors, and diagnostic accuracy analyses suggest that existing factors rarely correctly identify people who go on to engage in suicidal behavior. Okay, I'll read a few more. No scales have this, so these are all different authors. No scales have sufficient evidence to support their use. So this is specifically looking at risk assessment measures. The use of these scales or an over-reliance on identification of risk factors in clinical practice may provide false reassurance and is therefore potentially dangerous. Next one, the inaccuracy of suicide risk prediction has been known for 60 years. And they actually I went back and found the site because I didn't know this. It was sort of like just some folks saying like, yeah, the math of this does not make sense. That if you just look at how the frequency of suicide, that mathematically, this is just illogical. So my favorite one, just because of like how sarcastic it is, which I love, is the last one. The commonality of suicide risk assessment strategies appears to be their lack of utility at meaningfully predicting risk. I love that. Okay, from another review, among those that could be evaluated, none fulfilled requirements for sufficient diagnostic accuracy. In the current review, we found no scientific support for the use of risk assessment for predicting suicidal acts. Okay, so this is another thing. So this, the National Institute for Healthcare Excellence folks, there are probably some folks on here who have much more familiarity with it than what I do, but basically it's a sort of a British healthcare group. And so they put together a group of experts to write a report about suicide risk assessment, these sorts of things. And so this is from that report in 2022. Risk assessment tools should not be used to predict suicide behaviors, determine who should and who should not get treatment, stratify people into low, medium, or high risk status, or use stratification to determine treatment. Any assessment should instead be focused on people's needs and vulnerability. Okay, so yes, here I am a few years ago, sort of in the middle of all of this, reading all of this and being like hit with the tsunami of data and arguments and evidence for why not do risk assessment. And I was like, okay, so I'm going to be the good scientist that I try to be. And I was like, I'm going to look for the counterfactual. I'm going to look for strong arguments for using risk assessment. Right? That was my goal. So I find this paper, Why Suicide Risk Assessment Still Matters. And I'm like, oh, great. Here we go. I get to read the argument for it. This is a specific quote pulled from it. Suicide risk assessment, especially when limited to a structured instrument performed in isolation or in place of gainful therapeutic activity, makes little sense. When risk assessment occurs independent of more comprehensive mental health evaluation and treatment, it provides virtually no clinical benefit and may provide false assurances. So what they did in this article, and this is sort of a common argument that folks make, is they argue that the reason we should do risk assessment is that there's value in collecting data on your clients to understand why they're suicidal, what led to it, to understand all the stuff that's happening in their lives, basically to use it to facilitate a stronger case conceptualization that can inform treatment. That's what they're arguing. It's a common argument. That argument makes complete sense. And I'm going to go into that in a moment. But I think the thing that is often lost in this is actually, let me go to the next slide, then I'll hit on that point. So there's another caveat. I am not arguing against assessment with suicidal clients. I have a few examples here of folks who are sort of approaches that routinely integrate assessment with their work with suicidal clients. But what they use that assessment for is stuff like case conceptualization, personalizing treatment, helping clients become their own suicidologists. Like They use the assessment to inform and facilitate what I would argue is responsive therapy, responsive approaches. They're not doing it for prediction, they're doing it to facilitate therapy. That's great. What I think is lost in this argument, or I think the problem with this argument of we should do risk assessment because it facilitates those therapeutic because it has therapeutic benefits for informing personalization, conceptualization. But great, but that's not risk assessment. That's assessment. You could put it under any other category. But to me, and I don't think I'm being overly simplistic in understanding it this way, but when somebody says risk assessment, I think that the goal is to assess risk. So to do risk assessment for the purpose of strengthening your conceptualization, no, you're doing assessment. You're doing risk assessment to assess risk. And I think continuing to call it risk assessment is extremely problematic because it suggests to people that you're assessing risk. Like it just does. Like, again, I don't think I'm being too simplistic here. And lots of folks really do say this, sort of like make this argument. And it's sort of like, I think we're missing each other here. But as soon as you call it risk assessment, I think any reasonable person is going to assume you're doing it to assess risk. And if that's not why you're doing it, then call it something else. Call it what it actually is. Okay, so it'd be one thing if risk assessment was kind of this banal, not beneficial placebo thing that happens, right? That'd be one thing. All right, it's not really useful at predicting risk, but that's all. It's just kind of like, well, you wasted 15 minutes. But I argue that it's actually anti-responsive, that it actually gets in the way of and can impede the therapy that can be done and doing the stuff that can be helpful for the client that's sitting across from you. So one way, and there's several, but one way is what I sort of call the therapist bind, the bind the therapist is stuck in, which is, okay, so there's this expectation that I conduct risk assessment. Okay, so if there's an expectation I conduct risk assessment, then it must be the case that I should be able to predict suicidal behavior, because if not, why would there be this expectation? But actually, even though there's this expectation to do this and I should be able to do it well, I don't feel like I can. Like I must be missing something. I know I had this experience when I first sort of learned about risk assessment. I sort of felt like, did I miss a day of class where like this was like where this was covered? Because I feel totally inept in doing this. So that experience is common. So I feel like I should be able to, but I don't feel like I can. So I feel inept. So now that I have this client and I need to do this thing, which everybody tells me I should be able to do, but I can't do. So now I feel distressed. And so what happens when I feel distressed as the therapist? Now my attention moves away from the client to me because I'm feeling distressed, as it does in any situation where you feel distressed, right? Anytime you're the therapist and you're freaking out for any number of reasons, that the attention goes to you instead of your client. Just like, right, anything in the world, when you're sort of feeling that distress, your attention focuses inward instead of outward. So it moves away from the client. So it impedes my ability as the therapist to actually be therapeutic with the client. Because now I'm freaking out and I'm focusing on me instead of on being there in the moment with my client and attending to their pain. So let's add to that. There's work. I've done some of this work demonstrating that folks who are suicidal, there are actually some characteristics of those folks on average that can make them pretty challenging clients to work with. In particular, this is not surprising, they're often irritable. They're often in a bad place. They're often experiencing impaired problem solving, right? And there are other things as well. So you have this interaction where you have the therapist is distressed, so they're feeling anxious or whatever it happens to be. So they're somewhat impaired relative to their typical way of being. And then you have particularly challenging clients. So you have therapists sort of, I'll be extreme here, kind of at their worst, with clients at their worst. And so you have this interaction, which that can make for some really lousy therapeutic experiences. Okay. So give me a minute to imagine a case with me. So let's imagine a case where a person's in extreme psychological pain and is considering suicide as a way of escaping that pain. They don't want to die, but they also can't imagine living with the pain any longer. They make an emergency appointment with their therapist, and in that session, they disclose their suicidal desire. The therapist's response to this disclosure is to take out a risk assessment form and ask scripted questions about their suicidal thoughts and their suicide history. The client finds this unusual, as apart from a portion of their first session with the therapist many months ago, the therapist hasn't used a form or asked scripted questions. As the risk assessment progresses, the client starts to feel annoyed because the therapist doesn't seem concerned with helping them feel better, which was the reason the client made the appointment in the first place. As the client comes to the realization that the therapist isn't able to give them the relief from their suffering that they were hoping for, they start to withdraw in the session. One way to conceptualize this incongruence between the client and the therapist is as an alliance rupture. Alliance ruptures are when there's a strain, many of you will be familiar with this, there's a strain or breakdown in the collaborative relationship between the therapist and client, often characterized by mismatch or conflict in their therapeutic goals. And we're doing a study on this right now that we're just sort of starting. Dave's part of that. Thanks, Dave. And while still very anecdotal, what we see is that unlike other ruptures, or sometimes with other ruptures, that when this happens, that there is very little rupture repair that happens, that it tends to just not get addressed. Okay. So, if anything, I'm practical. So, many of you will work in organizations or feel compelled to do risk assessment. So, some practical strategies for dealing with that. How can I be responsive while still doing risk assessment? One, know that you can't predict. So let go of that expectation. Let that burden off of your shoulders, please. Just let it go. You can't do it. Just know that. Accept the ambiguity. As we know, we have very little control over our clients and their lives. This is no different than the context of suicide. So just know that you have very little control. There's, I think often, at least I felt this, a belief that I should be able to sort of really control what's happening with my client when they leave if they're suicidal. But you can't. The other thing I suggest is to know the tool. So this is kind of inconsistent with what I've been saying, or this might sound like that. But if you know the tool, if you're familiar with it, then it's not like you're taking it out and it's the first time you've looked at it in 9 months. So you want to have a sense of what's on the form, be comfortable with the tool, even if it isn't helpful in prediction, so that you can focus on the client, so that you can focus on prioritizing being therapeutic. Okay, so the second thing, and I'm getting close on time here. So let's see, we'll speed run this a little bit. So reconceptualizing hospitalization. So I do want to say this is another caveat that I have been convinced that in certain conditions, rare, but in certain conditions, that hospitalization can be responsive. I'll get to that in a moment, but I just want to point that out right at the outset. So this is what we say are the guiding questions for therapeutically responsive hospitalization. So these are the questions to ask yourself when working with a client when considering hospitalization. What are the foreseeable benefits and risks of admissions to this hospital for this client at this moment? So those are what we think are some of the things to really consider, the benefits and the risks, but then also this hospital for this client at this moment. Okay, so we're taught that hospitalization, or this is how I like to think about it. So this is how I thought about it. So when I was a kid, I played freeze tag. I don't know if anybody else played freeze tag, but in our version of freeze tag was if you were on base, which was the tree, the swing set, the steps, whatever it happened to be, when you were on base, you were safe. Nobody could freeze you. You were safe. that's how I think about how we're taught about hospitalization. The idea is when they're hospitalized, when a client's hospitalized, that they are safe. We're also taught that this is, even if it's just implied, that this is our ethical obligation. Both are incorrect. So, this systematic review, from the systematic review, it's unclear if hospitalization helps reduce suicide, but there's compelling evidence for increased risk of attempts and death following hospital discharge. So, a thing to know is that people often die while they're hospitalized and following discharge. While I was on practicum as a graduate student, I worked inpatient at a psychiatric hospital, and we had somebody die by suicide inpatient while I was working there. So hospitalization is in fact not safe when they're in hospital. And then also there's a there tends to be a pretty big uptick in suicide right at or shortly following discharge. So this idea of hospitalization keeps somebody safe is just bunk. Okay, so what are the problems with hospitalization? So I'll go through this just quickly. So coercive admissions. A shockingly high percentage of folks who voluntarily admitted themselves still say that they were coercively admitted, that they were sort of manipulated or tricked into hospitalization. It's not so surprising for those of us who have worked, maybe even do, that oftentimes the experience in hospitalization is that there are all sorts of challenges that folks experience with staff and the experience there. But then also, again, another surprising thing is that oftentimes folks, they don't even, patients don't even know if they can voluntarily discharge. And then obviously there are all of these other, responsibilities that they have in life that they can't attend to when they're hospitalized. I mean, just imagine if right now I took you and I put you in the hospital for 5 days. Think about all of the responsibilities that you have that now just get offloaded or don't get taken care of, all the things that are, all the financial obligations, the dependents, whatever, right? That now you can't do what you needed to do because you're in the hospital, right? This is these have real consequences, not surprisingly, for folks' mental health. So this is how I've come to think about, or sort of argues how we should think about hospitalization for suicide, is that we should think about it like we think about electroconvulsive shock therapy, which, and again, I'm sure there are folks in here who know a lot more about this than I do. My understanding is it's kind of a last line treatment for depression. It's used, infrequently because of all of the side effects, potential consequences. That's how we should think about hospitalization. That, yeah, maybe occasionally you decide, yes, this is right for any number of reasons, but we need to think about it as the high risk treatment that it is, the one that often does have lots and lots of costs, and those costs outweigh the benefits. Uh, okay. Real quick on ethics, because I think this is worth noting. So, I'm not a big um, read the ethics code kind of a guy. But when we were working on this paper, I was like, all right, I'm going to dig into this. And I did both the APA and the Canadian Psych Association one. None of them say anything about hospitalization or risk assessment or anything like that for suicide. And in fact, I was kind of surprised because I hadn't revisited or spent much time in it since studying probably for the EPPP, that there's a lot actually that argues sort of against hospitalization. So indirectly, of course. So psychologists respect the rights of individuals to self-determination. Responsible caring recognizes and respects the ability of individuals to make decisions for themselves. So let's see, I'm going to do this a little quickly. So our ethical obligation to be sufficiently sensitive to and knowledgeable about individual characteristics, culture, and vulnerability to discern what will benefit and not harm the individuals. And I think, we all get beat over the head with this in our ethics class, the beneficence and non-malfeasance stuff. But we should really take this into consideration when we are considering hospitalization. Okay, so I've more or less covered that. So one of the things that I also argue is that all of us live in a place, we live in a community, and if you are sending patients to a hospital, you're likely sending them to the same one or the same one, two, or three. That one of our jobs is to, I know this is a little bit annoying, but is to learn about what the hospitalization experience is like at that specific hospital, right? We aren't just assigning or sending clients into some treatment. We're sending them to a specific place to get in this, where they'll have a specific type of experience. It's reasonable for us to do a little bit of background work to figure out what is that experience like. To talk to colleagues, people at the hospital who we might know or we probably know through somebody, and even to talk to patients who have been hospitalized at those places. What was that like? How was it? So that way we have a sense of what that's like when we're working with our patients to maybe send them to. All right. So again, some practical ways forward. So using documentation to help you be responsive in what I think of as kind of this anti-responsive context, in a context where we feel like there's a lot of pressure to do things like risk assessment, prediction, hospitalization that can get in the way of being responsive. So this was so these most of these things have come from conversations that I've had with real experts about this stuff. Because again, doing this work, I've had to learn a lot about sort of ethics and legal stuff or whatever. But when you're doing when thinking about what is the standard that I'm living up to, it's to be reasonable. That as a mental health care professional, my job is to do my best to be reasonable within the context and the folks that I'm working with. So I need to demonstrate in my note that I'm reasonable in my thinking and in my decision making. So here are some very specific sort of phrases that I've had experts give to me to be that one can put into their notes. So like when it comes to documentation, when you're saying your reasons you're not hospitalizing, right? So I've considered this person could be classified under some schemes as having an elevated risk of suicide. However, I'm aware that the positive predictive value, that's the ability of if you're categorized as high risk, them attempting suicide, the of the high risk categorization over the next week is less than 1 in 1,000. So it's less than 1 in 1,000 that this person is going to attempt or is going to die by suicide. So that means it's extremely unlikely, right? So just communicating that in your documentation. I'm aware of the potential negative effects of the hospitalization. You can list those things. The patient is mentally competent. The patient does not want to go to the hospital. It'll disrupt their lives in the following ways, right? So again, demonstrating how reasonable you are in your thinking and decision making with your client. And then documenting what you're doing instead of hospitalization, right? Again, this is sort of like if you have to, if you're required to. So we've set up an outpatient plan we've completed a safety plan where we have a means restriction plan. I've talked to their mom, dad, wife, best friend, sibling, but whatever, right? And this is what we've decided. So again, demonstrating that like reasonableness in your decision making and working with your suicidal client. Okay, so some key takeaways. Drop the burden of prediction. You can't predict. So just take away that pressure, that weight on your shoulders. Use hospitalization only when it truly serves the client. Documentation can facilitate responsiveness. And bottom line, don't be predictive, be therapeutically responsive. So again, here's that article. Let me know if you want me to send you a copy.
Yes, please.
Okay. Special thanks
Do
to
that.
many colleagues and funders. And thank you, Dave, and others for shouting at my podcast. There it is as well. So if you're at all interested, it's awesome. Okay. Thank you very much. I think we have 10 minutes for questions.
Okay. Can you please remind me a little bit about if you're more a researcher or a clinician, or if you are both, or I didn't have time to really, but since I have done some thesis about suicidal young persons, I'm very interested in this subject. So,
Yeah, I'm much more on the researcher side of things.
okay.
Um, yeah, but uh, my interests are very practical, and I sort of, the implications that I stuff I write about generally, I think about my audience as practitioners.
Okay.
Yeah.
Yeah. Ah. Um, I'm just asking so I know what kind of um, um, are you focusing on the research about it or on the process? But I can feel you are a therapist too, aren't you?
Well, and I also do, so I'm a professor in counseling psychology, so we do a lot of therapist training here as well. So that's like
Oh, that's
another
nice.
thing I think about as well quite a bit and do a little bit of
What
research
kind of
on.
training then?
So
CBT or
what's that?
no? A CBT or
Oh no, so it's just so we have a master's program and a doctoral program in counseling psychology. So it's
Mhm.
broad.
Okay.
Yeah.
But are you doing dynamic psychotherapy with them or?
Oh, so it's a generalist training. So
Aha.
like I actually just taught our theories class, and so I tried to do a breadth of theories. So we did CBT, we did dynamic, we did EFT, we did ACT,
Oh,
we did something else too. We did other
wonderful.
stuff as well. But yeah, so it's
You have
pretty
you know many kinds of methods I can hear. That's nice.
learning.
Learning. Okay. Okay. Yeah. Yeah. Yeah.
I want to help
Mhm.
moderate the
Mhm.
questions here, and I noticed that we have one question in the chat, which I'll
Mhm.
read to you, Dan. But first, Jane has her hand up, so can we go to Jane for a question?
Thank you. First of all, thanks very much, Dan. A lot of it actually reinforces DBT approach in terms of explicitly finding out about suicide early on, and then it becomes part of the discussion. And it occurred to me, I'm not sure it has occurred to me in this way, but it's almost like if we allow and open the door for this conversation early on and in a open way, it's sort of like opening the door to anything else that's uncomfortable, sex
Mhm.
included. When the therapist is comfortable asking and talking about this as part of what this person's experience is, then it becomes more likely the person will, in fact, share what's going on. And the other point I wanted to make, because I think it's an important one, why we avoid hospitalization big time, is it because it makes our clients more passive. And passive people who are suicidal, deadly combination. And so we will work hard with our clients to make them as active in their own treatment as they can.
Yeah, those are both great points. And one of the reasons, and following up on that, the literature, the research on one of the reasons that people don't disclose their suicidality is because they're afraid of hospitalization. That's like consistently like the number one, number two reason why people don't. And I think it's sort of what you're saying in some ways is like consistent with that. It's sort of like there's a fear that if I disclose this, that it's not okay, because then that's going to set this process in motion and it's going to end somewhere that I don't want it to end. And then obviously there are cases where there are clients who are like, yeah, I think I need to go. I think hospitalization would be really helpful for me right now, right? Those cases do exist.
Yeah, I have heard of them, really, and I haven't been working as a private practicer, and I have never had any suicidal patients when I'm working alone. It was when I was doing DBT, and so there was a team around, and that was much more safe. Nowadays, after my dissertation, I really know a lot about the risks, so I'm not willing to take that risk. Actually, uh, rather, I'm thinking about learning perhaps more about other methods, or yeah, to do the therapeutic act, or I don't know really, but I don't want to work totally alone with no colleagues and like that. I know humor can be very good when you are working with these suicidal patients, and I know a psychoanalyst, actually my husband I'm speaking about now. He worked alone with suicidal patients, but unfortunately he's dead. So we can't ask him anymore. But I have heard from him how he worked and how hard it was and like that. But he had, like you said before, he had patients that could say, yeah, please drive me to the hospital.
Thanks for those comments. I want to get to the question that we have in the chat here. Dan, we have a question from Lisa around alliance ruptures. I'll just read this section. In our work developing the rupture resolution training model, we found that therapists initiate rupture processes much more than we give them credit for, which you alluded to in your talk. Furthermore, patients initiate repair processes more than we give them credit for. And the question is, how do we help therapists work with this kind of session process and manage their own anxiety? And I guess there's a question in there around how we help therapists both recognize their contribution to the rupture process, but also how we help therapists recognize patients' efforts to try to repair the rupture in the context of suicidality and I guess the risk assessment that the therapist may get into.
Yeah, Lisa, if you have an hour, we can flesh this out. But so in an attempt to deal with it in a minute or two, because man, there's a lot of fronts to hit this on. So one of the reasons that I push for taking that pressure, that burden of unrealistic prediction off of therapists' shoulders is to try to keep that focus, like to reduce that distress, to keep that focus less on the self and more on the client. So part of my thinking is that it's almost like, and I'm going to project here my own experience, but when I was, first learning about this risk assessment and as a student doing risk assessment and that sort of stuff, it's almost like I put on this different hat. I was like this different person, and the therapist person that I normally was, that sort of therapist mode, where I was very like, as much as humanly possible, client focused and really letting, and really like, really, just like it just changed. And so I think part of the way to deal with these challenges are to stop that, is to take that pressure off of therapists, that belief that I can predict, that I need to predict, that this is going to be valuable. No. Continue being the therapist that you are. Like, continue focusing on the client. Your goal is to still help the client. Like, in a way, I feel ridiculous saying these things, because how could that not be the case? Like, and I think this is what it's like. I mean, it's kind of crazy when you think about it, at least for me anyway. But that, like, why wouldn't we stop? Why would we stop focusing on helping the client in this exact moment? I feel like a lot of what risk assessment and the focus on hospitalization does is it like takes us, like, we actually have the skills to help clients who are in suicidal crisis. Like, we're really good at talking to people in distress, allowing people to experience their feelings, allowing them to understand their experiences, where they came from, what they're experiencing, to do it in a warm, caring, supportive, all that stuff, right? Regardless of your orientation, regardless of your approach. Like, we're not going to rush in with solutions to everything, right? Like, right, in our clients' lives, when they're talking to their partner or their best friend or whatever, about whatever they're struggling with, people in your real life, they jump to action, they could jump to problem solving, right? And that's just how it is. And one of the superpowers of the therapist is that we don't do that, generally speaking. And so, like, but we just like, we take off that hat. We like take our superpower and throw it out the window and do this other thing, which is ridiculous. Like, it's totally crazy making. It's like the people who trained us to do this are like gaslighting us. It's the weirdest thing. So I mean, the primary way to deal with this is just to continue being a good therapist. Like, that should be the focus. You should not be changing modes. You're still the therapist that you were 5 minutes ago, with the patient before that, with the patient last week, with this patient last week. So if you're doing those things, then a lot of the ruptures in relation to this probably won't happen. So that's the major argument that I make.
We do have another question here about your experience teaching counseling students about this, but I'm also aware of the time. We are at 11. We are at time here. It's clearly a topic that's generated a lot of interest and intrigue. And like you say, Dan, we could easily go on for another hour, if not a lot longer. But I think we have to stop here for today. And I just want to thank you, Dan. You've given us a really rich discussion and a lot to think about and take with us with our research, training, and practice. And again, thanks to Emily and the communications committee for putting this webinar together. And thanks everyone for joining us.
Thank you, everyone. Thanks,
Thank
Dave.
you.
Thanks,
Thank
Emily.
you.
Thank you.
Bye, everyone.